All right, so in summary, don't freak out about the calculations. Don't freak out, right? With everything in my class, like people overplay it. It's just math. Math is easy, right? We can do math, but you need practice, right? You need to look at it. You need to go through it a few times and make sure you understand how I got from step to step to step. The biggest thing I can tell you is make sure your units follow, right? So if I'm multiplying a milligram per dose times milligrams per whatever happens to be, things need to cancel out appropriately. You should always look at the question and say, what am I looking for at the very end of that? If I'm asking how many mLs per dose should that patient get, that's what you should end up with, is mLs per dose, right? That should always be the last thing you need to run into. If you're not coming up with that, then you probably skipped a step or did something goofy along the way, okay? So always look at what I'm actually asking the question. I'm not going to be tricky with these. It's going to be very straightforward. If your answer is not one of the answer choices very exactly, you did something wrong, okay? I'll just tell it to you straight out. I'm not going to give you like, well, I came up with 9.43, but this answer says 9.38. Like, I'm not going to get that granular with it. It's going to be like 5 mLs, 10 mLs, 20 mLs. Like, it's going to be things like you should be able to reasonably to it out. You know, you'll have calculators you can use as well to double check your work, but this is not going to be, we're not doing calculus here, right? It's something you're going to get comfortable with. You're going to do day in and day out. If you work with pediatrics, it's just going to become second nature to you. So again, this is just your first introduction. The other thing I was going to say is that, so someone's asking like, why is it the 4-2-1 rule? I don't know. There's basically there are calculations that you can figure out basically what a child's volume they should get throughout the entire day is going to be. And so they said, well, this is a quick way to get that volume, right? Because again, as a practitioner, you can sit there and figure out, okay, well, the kid weighs this much and they're this height, and we're going to figure out what their ins and outs are and blah blah blah, and you can do all that stuff. But at the end of the day, you're writing orders and you got to go see 10 more kids. You just want to get something quick, right? So 4-2-1 is a quick way. You're not going to get yourself in trouble by doing that, right? And someone said, well, what about adults? For adult patients, typically you see that 125 mLs an hour is considered like the maintenance. That is based off of the fact that adults typically need about 3 liters a day, and if you divide that out by 24, it's about 125 mLs an hour. You could still do 4-2-1 for adult patients. That would be totally appropriate. You'll still get roughly the same number. It'll be probably close to that 125, somewhere around there, but that's probably even better if you have someone who's really underweight or really overweight. You can maybe get a little bit better idea of what they need to be taking, right, or what they should be administering per hour. Makes sense? And I posted up that document so you can look at that. You can look at all the calculations. If you have any remaining questions or concerns or fears and anxieties, just message me. We can talk it through. Again, don't worry. People overblow my class way too much. What did you say? You can call me. If you can find my number, you can call me. How about that? Unfortunately, I think it's probably out there somewhere. So my CV's probably floating around somewhere. It's got it on there. Change my number. Yeah. Yeah, so again, just think it through, give it a day, let it kind of settle a little bit, and then go back and look at it, and I think it'll make much more sense, right? So right now we're just in the heat of the moment, just let simmer a little bit, and then you should be able to go back and figure it out. All right, anyway, so moving on, this is our second to last section here. This is going to be about therapeutic drug monitoring, which is levels of drug in the blood to determine if we're in the right zone, right? So we want to find, make sure we're high enough to get the therapeutic effect we're looking for. We want to make sure we're low enough that we don't actually have toxic effects developing here. And so 2 of the terms we're going to use very frequently are called peaks and troughs. Peaks just means what? The highest level you're going to achieve. Troughs means the lowest level before the next dose, right? So if I was looking at, say, a steady state dosing here, in this graph on the right, here's the peak, it's the highest level I achieve. Trough is the lowest level prior to the next dose, right? And remember, how long does it take to get to steady state? 4 to 5 half-lives of the drug, right? So again, for some drugs, that's a really long time. For some drugs, it's not very long at all, okay? So just remember, 4 to 5 half-lives to get to steady state. That'll become important in a minute. Okay, and again, remember, we can achieve the same average steady state with very different dosing strategies, right? So I can go with a really big dose and only give it every 24 hours to get the same average concentration as I do for giving something, say, every 8 hours at a much smaller dose. Now, what is the benefit of giving something at a much bigger dose less frequent? More compliance. Man, I don't have to give it as often. Great. What could be the downsides of doing that? Toxicity. Not only the levels may be too high for the patient, but what about on the low side? Maybe you lose efficacy, right? So in some cases, you have to dose it more frequently in order to make sure you're maintaining your levels within the right range there, okay? So again, that's the main reason why you'll see that. And again, 4 to 5 half-lives before it gets to steady state. One of the things you're going to find, if you check blood levels of the drug too early, say I do it after the second dose here, what am I going to think about those levels? I'm probably going to think they're too low, and then what am I going to want to do to the dose? I'm going to want to increase it, and then guess what? Then the levels are going to be too high when they actually do get to steady state. No good. So you want to make sure you're always at steady state prior to checking those levels here. It's one of the biggest pitfalls that I find people run into. They check levels too early because they use it as a security blanket. They say, okay, well, the level's not too high, I'm good to go. But then you're also going to make this thing is too low, and you're going to want to adjust it up, and then the patient will be too high. So again, using this information, we can try to apply these pharmacokinetic principles to try to determine, what's the right amount this patient needs to get. How often should they get it to make sure we get the right amount of drug at the receptors to do their thing, and make sure we're not going to cause toxicity for our patient, right? The thing about therapeutic drug monitoring is we're going to be applying this to single patients. We use things like population kinetics. Like if you remember looking at those charts when you looked at volume of distribution, every drug had a volume of distribution to it, right? In liters per kilogram. Well, I'm taking that information, which was defined from populations, and I'm trying to apply it to a single person. Now, is that single person going to be exactly the same as the population I'm pulling from? Often no. Oftentimes you're going to find they're different. Every patient's a little bit different in their own way. And so what you're going to find is we're trying to individualize care. So that way one patient getting vancomycin for an MRSA infection is going to be getting a different dose based on their neighbor in the next bed over who has very different kinetics from them, right? We're going to look at why that is going to be. So early on, again, we were looking at things like therapeutic ranges. Now, do we do this for every single drug out there? Typically, no. We only want to do this for things that have a narrow therapeutic index. When I say narrow therapeutic index, what does that mean? Yeah, the overlap between efficacy and toxicity are very close to one another. It means it's very likely that if I have small changes in dose, I'm either going to be likely to see little efficacy or too much toxicity. And so these are the drugs we're typically going to do it with. I'm not going to make you memorize a list, but when we talk about drugs that need levels done later on in Pharm 1 and Pharm 2, that'll make sense of why that is, okay? Okay. Again, I said therapeutic range, if they're too narrow, this is where we're going to be looking at using our therapeutic drug monitoring, actually measuring blood levels to make sure we're in the right range there. Right? And again, things have a very wide therapeutic index, and this is good. We like drugs that have wide therapeutic indexes. I don't need to look at levels of that drug because if the drug's not being efficacious enough, guess what? I can up the dose, but no, it's very unlikely they're going to develop toxicity. So that's okay. So I don't have to worry about checking levels, right? Those are good drugs. However, a lot of them are not going to be good drugs like that. They're going to have a narrow therapeutic index, which is why we need to worry about this. Okay. Anyways, we know what that is. And again, we know that there's going to be some pharmacokinetic variability here. This is what we're usually trying to account for when we are doing therapeutic drug monitoring, right? When we're trying to figure out what the right dose is for that patient, we're trying to see, okay, well, is their absorption different? Is their metabolism? Is their distribution, their excretion? Are any of those things different to the point where I need to alter the dose and the frequency to make sure I'm getting the right concentration at the effect site? And then, of course, some patients are going to have pharmacodynamic variability, but we can't have as much control over this, as we'll see. And again, lots of reasons for variation here, right? So again, it could be due to things like, is your patient pregnant? They have very altered pharmacokinetics compared to a non-pregnant patient. So obesity, age, genetic differences, all of these play a role here in trying to determine what this variability is going to be in determining, okay, well, how do we need to monitor this drug? How do we need to actually dose it specifically? What do we need to do to make sure that we get a very personalized dose for this patient that's going to be just right for them, right? It's kind of like Goldilocks where we don't want it to be too hot, we don't want it to be too cold, we want it to be just right for that patient. Okay, and we've been doing this for decades now, so we realized pretty early on that even at standard doses, a lot of patients were still having adverse drug reactions, right? And so again, this is back in the day when we're using a lot more dangerous drugs than now. However, we still see that even at normal doses, things we consider normal doses, people may be getting too much of that drug. And so we were starting to look to see, like, okay, well, in some cases, we're going to find that drug concentrations are a better surrogate for the action at the receptor than just looking at, say, the standard dose I'm going to administer to them. And this is the ones that we're going to be using for therapeutic drug monitoring, right? Now, there's going to be a lot of drugs that have a narrow therapeutic index that we're going to monitor in other ways. We'll talk about some examples of that in just a few. Hey, I'm just trying to get through this pretty quick so that way we can get to all the material in a timely manner. Try to have a little bit of review next week. But anyway, so some things to consider. This only applies to a relatively small number of drugs. Many drugs you don't need to do drug levels for because I can actually monitor the efficacy based on other markers. So for instance, if I'm giving you a drug to lower your blood pressure, do I need to measure the levels of the drug in your blood? What can I measure instead? I just measure your blood pressure, right? If your blood pressure is going down, that means the drug's working. If it goes down too low and you're hypotensive, the drug's working too well, right? So then I can alter my dose based on that, right? Same thing for glucose, same things for serum cholesterol. I can monitor all of that, right? Now, other things you can look at, some other measures that can be a marker of how well the drug is working. So for instance, warfarin is an anticoagulant. We use it for patients like AFib or DVTs and PEs and things like that to try to prevent them from clotting. Now, do I want to wait for the patient to get a clot before I say, hey, I probably should have adjusted your dose up? No. We want to look at other things to show how thin the blood is, and I can use something like PT-INR. You don't have to memorize this for this test, but this will come up later on when we talk about blood thinners. But we measure PT-INR as a surrogate for how well that warfarin is working. I don't need to measure the level of the drug. I can look at the PT-INR. It's usually a lot easier way to do so. Okay, it tells me how well the drug's working. So some assumptions we have to consider when we're going to do therapeutic drug monitoring. One, we're going to say that, hey, measuring the drug concentration gives us the ability to alter the pharmacokinetic, or to adjust for that pharmacokinetic variability and individualize the dose, right? So again, if a drug only comes in one way and there's no way to change that, which is very often not the case, we can alter the dose, we can alter how often we're giving it. So that assumption usually holds true here, right? The one other assumption here is that drug concentration is a better predictor of response than just the dose they're getting, right? So again, this is good for narrow therapeutic index drugs, maybe where you need to make sure you get a level up to a certain point to make sure that you're actually going to have efficacy. So a good example of this is the drug vancomycin. It's an antibiotic we use for gram-positive infections, usually MRSA. Anyone know what that stands for? Methicillin resistant Staph aureus, right? So MRSA. And so if you have meningitis, right? So if you have inflammation of the meninges, having this infection of the CNS, we need to make sure we drive levels of that drug really high because it really needs to make sure it's getting into that CNS. Usually the CNS likes to keep drugs out. We want to get that drug in there because we know that's where the infection is. We want to make sure we just don't give a standard dose because we have no idea if that drug level is getting high enough to actually get into the brain to kill the bacteria, right? So this is why we have to look at the drug level. That's a better marker than just the dose that we're going to administer to the patient, right? And there should be a good response between drug concentration and the response we get from that patient, okay? All right, so we mentioned things that we do not control. We cannot control the bioavailability of the drug, unless we're changing like maybe the route they're giving it, but we cannot change the clearance of that drug from the patient, right? I can't make their kidneys work better magically unless I maybe put them on dialysis, but I can't make the liver work any better, not necessarily. However, I can control the dose I'm going to administer, and I can control how frequently I give it, right? Those are the big things we're going to do. Now, we say therapeutic range, and you'll look at drug references, and you're going to see, okay, the therapeutic range for this drug is 10 to 20 mics per ml. That's not absolute, right? You can have patients that fall below that who are still getting good efficacy from the drug. You can have patients that go above that and are not having any toxicity. That's totally possible. You can have patients at the normal, within the right in the middle of the range, still having terrible toxicity. So it just depends on the patient how they're going to be responding to that. Because again, lots of people fall outside of that normal bell-shaped curve, right? And you're looking at like a normal distribution. Have you guys covered any like biostats yet? Anyway, people fall outside the normal all the time, right? So everyone's a little bit of a snowflake. Anyway, but we do this based off probabilities. We think most patients should do well when they're within this therapeutic range, and that's why we shoot for that, right? Basically, what we're saying though is if you go above that range, the chances of toxicity are pretty high enough. We want to stay below that. And then if we get the levels too low, then we know the drug's not going to be efficacious. But you always want to make sure you treat the patient and not the number, right? So if I have a situation where I have a kid, I'm treating for seizures, and their level of the drug comes back below the therapeutic range, but they haven't had a seizure in a year and a half, do I need to adjust that dose? Yes, sir. All right. The opposite is also true. The level comes back a little too high. Kid's not having any toxicity, no seizures. Do I need to touch the dose? Probably not, right? If it's not broken, don't try to fix it, okay? Again, always look back at the patient, not necessarily just look at the number. Okay, so some other things you want to consider. Generally when these ranges were determined, it was in a pretty small subset of patients, right? And again, when you're trying to apply this to millions of different patients, you're going to find they fall outside of that. And so, oftentimes it's hard to determine that validity of those published ranges. Try to go back and say, well, okay, well, were they only looking at 40-year-old white men? Like, can I apply that to my female patients or my pediatric patients? Not necessarily. And so you have to go back and look at that to say, okay, well, is this even a valid range to begin with? But you'll find a lot of these things have been done for years and years and years, and that's just kind of why we stick with it for this time. And so you may see some changes, but oftentimes those ranges are pretty well set. Okay. Again, so when we're trying to go for a target concentration, usually you try to shoot for right in the middle. So if I have a level, a range that says 10 to 20, you try to shoot for 15 or so. So that way, at least when you're doing your drug dosing, you can try to go for a pretty specific target there, right? And basically what we're going to do is when you have a patient, unless they have some obvious difference, you're going to kind of assume they're like an average member of the population, right? So assume they're going to have average kinetics just like you would see reported in your lexicomps or micromedics or Hippocrates. They'll give you a list that says, here's what the volume distribution is, here's what the elimination is, the half-life. That's based off average population kinetics, right? So you assume your patient's average until proven otherwise. And then based off of that, you'll figure out what their actual dosage regimen is going to be, right? So you'll figure out, okay, here's the volume distribution for this drug. I'm going to apply it to this patient based on their weight, and then you'll come up with all your dosing and whatnot, and that should work for that patient. But then, how do we adjust it afterwards? Well, we'll take blood levels, see what the level is in the blood, and then adjust from there. So the question is, if we're measuring these levels here, the question is the dose at steady state, right? So we're going to keep dosing until we're at steady state, which is roughly 4 to 5 half-lives, as I mentioned, before we actually check a level. Again, typically if you do it too early, it's going to be falsely low, and that's going to lead you to adjust your dose up, which is no good. Now, you can have two scenarios here. One, you have an adequate response from the patient, and you just continue treating, you don't have to do anything. Or the other case may be you get a response that is subtherapeutic, meaning too low of a response, or they get a toxic effect. And at that point, this is where we need to consider changing the dose of the interval. So this is more often than not what we run into where we have to go and start to adjust these doses here. Okay, so looking at the reasons why we actually want to check levels, like why would you want to do levels on a patient? Well, one, this should be providing some sort of additional information that you're going to use in conjunction with other data to make some determining or make some decision about a patient, right? So again, if I ask someone why you're getting a level and they said, well, just cause, that's never a good reason to order anything in medicine, right? Because again, it's inappropriate use of resources. You don't want to do that, right? You want to make sure you have good judicious decision making in what labs you're going to order here, right? Now, again, this should provide the basis for individualizing that dosage regimen. So if you get a level back, and even if it's too low, you're not going to change the dose, then what was the point of doing it in the first place, right? Other reason you want to do kinetics here is going to be, has something changed in the patient. So for instance, has the patient become septic and now their kidney function has taken a hit, now their kinetics are far different than when it was 2 days ago. That's a good reason why to change this, right? Or if there's maybe some sort of drug, food, herbal interaction, it could be another reason why you want to go check levels as well. Now, what about adherence? Can I use levels to check for adherence? Absolutely, right? So again, presumably, if my patient's taking the drug, it should be in the system, right? What are some cases that may not be some cases that may not be true? You're selling them? Oh, interesting. Yeah, I ran into, when I was on rotations, back when I was a little bit more naive, I was talking to some people that worked in the pain management clinic and said, oh yeah, we're doing levels for hydrocodone for this patient. I was like, well, you prescribed him hydrocodone for his pain. Like, why wouldn't he be on hydrocodone? Why should you insist? And they're like, come on. So once I figured it out, I was like, oh, they're selling it off. And then that would be grounds for kicking them out of the practice to say, okay, well, if you're not going to be adhering to your therapy, then you're out of here, right? My wife, she did her second year residency in pain management at the VA. And so she had to do a portion of it working in their pain clinics there and all these old vets coming in for their pain meds. And there's this one guy who come around and he had this guy who come in on this hover around scooter, right? So come rolling in a scooter and he had this lady on his lap every single time. And she was just like dressed to the nines and she was just all blinged out. She's a beautiful woman, right? And he was there to get his OxyContin, right? All of a sudden, for whatever reason, I took him off the OxyContin. Guess what happened? The lady wasn't there anymore. Very sad for him. But it goes to show you, right? Just because you prescribe a drug for the patient doesn't mean they're taking it, right? So again, sometimes we do levels to make sure they're actually being adherent to it, actually taking like they're supposed to, right? Don't be cynical, but eventually something might get a little jaded, but stuff happens. All right, so anyway, other reasons why we commonly request drug levels, so things like if we suspect toxicity is occurring, we can link that back to the level being too high. It could be one thing we do. If they have a lack of therapeutic response, worried about adherence. Other things, if we want to assess for changes in the dosing regimen. So if I up the dose or changed it to be more frequent or less frequent, I want to follow up on those levels to make sure they're in the range now. Changes in clinical status of the patient, as I mentioned, they go septic and their blood pressure is low and their kidneys take a hit, like that's a good reason to check it there, or for other potential drug interactions. These are all really common reasons why we check levels for drugs. So things you want to know when you're trying to interpret these levels here. So one, the time the blood sample is taken. Why does that matter? We need to know when it was taken in relation to what? Okay, so if the patient is steady state or not, but also what? When was the last dose, right? So when was the last dose actually administered versus when was the level drawn? Is this a peak level? Is it a trough level? Sometimes hard to tell. Do you need to know the time the dose was given? You want to know the dosing regimen, obviously. Sometimes you're the one that set that, but sometimes you're following up on someone else who maybe had prescribed that. Patient demographics, obviously, look at their concurrent medications. The reason why you're monitoring, are you just checking a level because it's been 6 months and you're just checking to make sure they're in the right range, or are you checking for some other reason? You want to know that. And then, obviously, you need to have a desired range. Like you need to know what kind of range you're shooting for. I'd have patients, these neurologists who would order levels for antiepileptics that don't have an established range. I'm like, well, what are you checking the level for? If you don't know there's a range, he's like, well, I just want to check it. Not great, right? Not a great reason for it in those cases there. So you always want to have a good reason. You want to have some range to check it against. And again, not every drug has an established range that says, yes, this is when it's going to be efficacious, this is when it's going to be toxic, this is when it's going to be less effective. Not every drug has that, unfortunately. Okay, so some common things we're going to see here, with drugs that have no clear observable therapeutic or toxic endpoint, that's not going to be great for getting a good level on that. Sometimes there's kind of an intermediate point where, especially for things like warfarin, right, we're thinning the blood. Well, you want the blood to be thin, but not too thin. And so again, there's sort of an intermediate range you're kind of shooting for there. And so sometimes that may not be the best sort of drug to do those kind of levels on. But what we're saying here is that we think the concentration of the blood should be a surrogate for what's actually happening at the site of action, right? So, for instance, we were dealing with, like, say we were talking about pediatrics, we were talking about gentamicin. We said it's a very hydrophilic medication. It's very far distributed out to the tissues. If we're measuring the blood, well, what if we're treating infection that's not in the blood? Like, yeah, we're not measuring the actual level of where the drug actually is working. However, we use that as a surrogate to determine, okay, well, I know if it's this high in the blood, it should be this high out in the tissue. And that's why we use that as a correlation there, okay? And again, these drugs are going to have narrow therapeutic indices here, where again, lots of variable pharmacokinetics. If a patient's renal function changes, liver function changes, it's going to definitely affect these drugs pretty dramatically. So anyway, again, other things we're going to see, there's typically going to be some risk associated with these drugs. So again, from a toxicity standpoint, the levels are too high. Obviously, you can see problems from that. However, we also want to check for drugs that have a problem if their levels are too low. So for instance, if I give an antibiotic, typically I want the drug levels to be high enough to actually kill off the bacteria. If it's below that and it's not doing its job, it's not going to be very effective. So that's another reason why we do that. And then typically we want to see pretty stable sort of pharmacologic effects. So it really shouldn't be a ton of variability in the dynamics for the patient, but because we're trying to take into account at least what the kinetics are doing there. Okay, so the other thing to consider is the drug assay itself. So it should be pretty accurate, should be very precise and specific for the actual drug you're actually testing for. And you make it sound like, that should be kind of a no-brainer, but you'd be surprised. So for instance, you have to consider things like, what kind of tube is the level actually drawn in? But there's different colored tubes out there. Anyone that actually did phlebotomy, but there's all kinds of different tubes, right? So some are good for this type of test, some are good for this type of test. And so some of them actually have lithium in them. Lithiated tubes. What happens if you draw blood for a lithium level and you put it into a lithiated tube? It's going to look too high, obviously, right? So some of them have heparin in them. Is that going to affect blood clotting? That can make the level look like it's going to be the blood's too thin when really it's not. So these are things you have to consider. And again, sometimes you can have false positives for things, so this is why I hate urine drug screens. I think they're very pretty much useless for 99 times out of 100 people order them for patients. However, there's a lot of false positives on there, a lot of false negatives as well. So for instance, if I have someone who has who comes into the ER and they're very sedate and pinpoint pupils and their respiratory rate is say 6, do I need a test to tell me that's probably an opioid? No, I'm probably going to give them Narcan and wake them up, right? So you need something very specific. A lot of opioids actually don't even show up on a urine drug screen, so you can order that, and if they're negative, still doesn't mean the patient's breathing now, right? You still have to go back and treat that patient as you would. So anyway, other things, reasonable turnaround time. You want these things to be able to be turned around within, the course of several hours or so. If it takes me 2 weeks to get a level back, it may not be quite so useful. So a good example of this from my world, from toxicology, is going to be if we suspect a patient has a toxic alcohol ingestion. When I say that, I mean things like radiator fluid. I mean things like methanol found in windshield washer fluid. Those levels we cannot get easily here in Florida because, again, we don't have a lot of ingestions of that. It's not really financially reasonable for a lot of hospitals to be able to run that in the hospital, right? They run that there. We could send it off to somewhere and we can get results back in a couple of days or so, but guess what? By then my patient's either dead or alive. It doesn't do me a whole lot of good, right? So oftentimes we have to treat them as they are toxic alcohol ingestion if we have a high clinical suspicion until proven otherwise, right? However, if you go up north where it gets a lot colder, they typically have a lot more ingestions of that stuff. You're going to find they have very ready access to those levels. So they can get a level very quick, within an hour or so, determine if that patient actually ingested that product or not. Right? So again, sometimes it depends on where you work. And hopefully it's going to be relatively expensive. Oftentimes you're going to find that things are kind of not done routinely. Things you have to send off for typically going to be a lot more expensive. So if I have to, whenever we want kind of like an oddball lab, we have to send it off to Mayo Clinic, right? So we have to get a courier to get it up to the Mayo Clinic up in Jacksonville, do the lab, and then comes back. And so by 2 weeks later, maybe we'll have a result. But again, depending on the clinical situation, may be useful, may not be, right? Okay. So some commonly monitored drugs we would do this for, a lot of anti-infectives, things like vancomycin, the aminoglycosides. These are probably the two most common ones you're going to do if you work within the hospital. A lot of patients get started on these drugs for kind of broad spectrum coverage of infections. Oftentimes you're going to find that your pharmacy buddies in the hospital will help out with this. So actually we have pharmacokinetic monitoring services where we'll actually, if you write for a pharmacy consult, we'll do all the work for you essentially, right? So that's kind of nice. But if you work somewhere where they don't have that program, guess what? Who gets to do it? You get to do it, right? We do this a lot occasionally for, yes, sir.
The drawing like flags and stuff like this, does it really matter if you're drawing from an IV line versus a syringe?
We'll talk about that a little bit later. Just you wait. Good segue. Some other ones we have, cardiovascular drugs, things like digoxin we'll do that on, because again, with heart meds, you typically have a pretty narrow therapeutic index. As I'll allude to when we get to the cardiovascular section, any antiarrhythmic can also cause arrhythmias, right? So they can actually cause the problem that you're trying to treat, just like any kind of anti-seizure med. Guess what? Can cause seizures, right? It can be a potential side effect. So it seems kind of counterintuitive, but it happens. And so that goes to show you that we have anti-epileptics here are very frequently done for pharmacokinetics here, right? In some cases, we'll do things like immunosuppressives. So things like tacrolimus we'll use after organ transplant. Because again, with say like an immunosuppressive like that, what's the problem if my levels get too high? I'm suppressing the immune system too much, which means you get infection. However, if I have my levels too low, I'm not suppressing the immune system enough, they can reject the organ, right? So they can reject the tissue. It's no good. So these are things that have a very near therapeutic index. Oftentimes, if you goof it up and you're too low or too high, you can cause some serious bad effects for your patient, right? Okay, so some limitations here. Obviously, it's going to cost more than if you weren't doing any levels at all. You know, consider if you have a very wide therapeutic range, it may not be quite so useful here because again, depending on standard dosing, you're probably going to be pretty likely to get it within that range if it's very wide. That's why we shoot for things that have very narrow sort of range there. Again, I mentioned if we don't have a good established range, if no reference range is available, having a level doesn't necessarily help you because you don't know if it's too high, too low, or in between. You just don't know. And then, as I mentioned, if you have direct response measures, you don't have to worry about that. So, for instance, with blood pressure, I can measure your blood pressure and know if the drug's working or not, right? But for seizure medications, how do I know if a seizure drug is working? They don't have a seizure, but how long do patients have between seizures? They can go months sometimes. Like you have no idea if the drug is working or if they just didn't have a seizure, they wouldn't have had one anyway, right? It's kind of like elephant repellent spray, right? I can spray a bunch of elephant repellent spray, but guess what? It's working. There's no elephants here. Or is it just because we don't have elephants here roaming around Florida normally? So that's the kind of the question. So sometimes you need those ranges to say, okay, well, I don't know if they would have had a seizure or not, but most likely if they're in this range, they probably won't have one, right? So that's kind of things we're shooting for. Okay, some inappropriate uses. If we're ordering levels too often or we're just getting the routine, like we're just going to get weekly levels because we want to, you know, unless there's like a really big change in your patient, you probably don't need to check levels, right? You know, looking at things like, you know, the concentrations for patients that are responding appropriately. So for instance, if I'm giving an antibiotic and the patient is, the white count's coming down, their fever's coming down, they clinically look like they're improving, do I necessarily need to get a level? Maybe not in those cases, right? As I mentioned, you know, getting changes or getting levels in patients with no obvious changes in physiologic function, that's not really a good reason to do as well. And then more often than not, the big problem we run into is levels being taken at the wrong times, right? So again, a level will get marked as a trough level and it comes back extremely high. Chances are the nurse probably took it after the dose was actually given and it's actually a peak level, not a trough level. Those are things we have to consider there if timing is not going to be appropriate. So what we know, we do know that it does lead to things like reduced number of patients getting toxic, which is good. It also can help with things like keeping drugs in the ranges for longer, which means they will get there quicker and stay there for longer, which means they're going to be efficacious. And in some cases, you actually find decrease in hospital stay and increases in mortality, or decreases in mortality, I should say, for Again, hopefully you're going to have reduced toxicity, improved effectiveness. Hopefully it's going to be cost effective and maybe more rational drug use of these concentrations or use of these concentrations. As I mentioned, here's just some drugs that have been shown via the literature to actually have some improvements here after using therapeutic drug monitoring. Again, some of these we don't use quite so frequently anymore because we have drugs that have wider therapeutic indexes that we'll use now. So for instance, you don't see as many patients on lithium anymore for bipolar, but they'll oftentimes be on anti-epileptics that can be used as mood stabilizers that we'll do levels for. But very, very frequently, we're doing this for aminoglycosides and vancomycin. Those are two most common ones you're going to run into in the hospital. Okay, so let's look at our steps here. Let's look at how we're actually going to do therapeutic drug monitoring. We've got all the baseline stuff out of the way. So one, we want to see what's our actual reason for monitoring, right? Do we have a specific indication, or are we checking for something else? We're looking for lack of response, side effects, the therapeutic doses. What are we looking for? Next, look at the blood sample collection. And again, this is where documentation is key. Nurses have to document appropriately when they took the levels, when the doses were given. If they say, for instance, they do all their stuff and they go, an hour later and then go document everything afterwards, it's less likely to be accurate, right? You need to do things in the moment at the time, so that way everything's done accurately, okay? The right collection tube, as I mentioned, if you have a lithiated tube and you're getting a lithium level, it's going to come high, and we just know that. Look at the laboratory measurements. Right? So you actually have that come back and actually make an evaluation of that. And then you have to look at the communication of results, right? So the question is, what units are things being reported in? One of my scariest moments when I was in fellowship is I was dealing with an aspirin overdose. And typically, like an aspirin level, a normal aspirin level, say 15 to 30, right? And say potentially fatal levels, say like 80 to 100, right? This is milligrams per deciliter, okay? And so I was calling this provider up and I said, hey, what was the level for the aspirin for that patient? They came back and it was a nurse and she's very kind of nonchalant. It's 400. I was like, oh, well, the patient's dead. What happened? No, the patient looks fine. He's breathing a little fast, but he's okay other than that. I said, well, what the heck is going on? I was like, what units are those labs in? Because the nurse didn't mention it. She said 400. Oh, it's in micrograms per ml. So, okay, so let me convert that back over to the standard, which is milligrams per deciliter. It turned out his level is 40. Okay, it's high, but not going to be fatal at that point, right? So again, you have to make sure you communicate those units effectively. Otherwise, you could be talking apples and oranges, and you can't make good decisions based off of that, right? Okay, so next, once you have the levels back, you want to take the whole clinical picture into account. How's the patient doing? Are they getting better? Are they getting worse? Are things going in the right direction? You have to take that into account. And then you're going to look at optimization of the drug treatment. So again, do I need to change the dose? Do I need to change the interval? Or maybe I need to do both. Typically, we try to do one or the other, but in some cases, you do both. And then you rinse and repeat. You let that new dosage regimen get to steady state after 4 or 5 half-lives, and then you go ahead and rinse and repeat. Get another level, see where it's at, and then you can adjust the dose again if you need to. Okay. So, typically therapeutic drug monitoring is pretty reactive, and you may find in certain patients being able to look at things like pharmacokinetic, you may be able to get a little bit more proactive as the case may be. And this can actually help us to guide, like, okay, well, I know this patient has this sort of mutation. I know they need this sort of drug dosing. This will help us to get there a little bit faster in some cases. You may see that more commonly in the future. Just depends. Like, so for instance, like warfarin, there's a lot of genetic tests we can do for warfarin to see if they're going to be fast or slow metabolizers. Other drugs we can do that for, but that'll become more common as time. And it will allow us to select out the patients who's going to have a good response to the drug, who's going to have a poor, or maybe who could be at risk for toxicity, right? It helps to kind of segregate your patients out a little bit, decide who's going to be the best person for that drug. And be able to get faster decisions on kind of what drug to try. Because typically today you're going to go, okay, well, let's try drug A. Okay, that didn't work. Let's go try drug B. Okay, that didn't work. Let's go to C. Okay, let's try D. Well, maybe we'll go back to C again. See if that worked. Maybe a different dose. Instead, if you can have more objective sort of findings to say, okay, well, I know you're going to be a bad responder to this drug because you have this mutation. Let's go ahead and use this one instead. And that way you can go directly to the drug that's going to work for that patient. That could be good. And hopefully that'll be more common as time goes on, right? Okay. So let's say, for instance, let's go ahead and look at this patient here. Let's go do a quick case. So let's say we have a digoxin patient. We have a patient who's going to been on digoxin for 15 days. It just got started on it for, let's say, for AFib, and they appear to be doing pretty well clinically. Okay, we look at digoxin, we get a plasma level here, and it comes back reported as 3.4 nanograms per ml. All right, so already noticed it's a kind of a non-standard sort of unit there, but nanograms per ml, not a lot of drug. And the therapeutic range is 0.5 to 2. So looking at this, what do you think? Level too high. So what are some reasons you think it might be too high?
You're just taking your medicine.
Maybe she just took the medicine. Maybe she took too many. Right? Maybe she's taken did a double dose. Older patients tend to have memory impairment. Maybe they took an extra dose. Maybe. What else? Maybe renal impairment. Maybe we did not take into account the renal function to begin with. Right? These are all really good reasons why levels might be too high. So the question is, when was the dose taken, right? So you ask, okay, when was the last time the dose was taken? Was it yesterday, today, whenever it was? When was the blood drawn? You want to make sure you kind of know that difference there between those two time periods there. And obviously have ask her what her dosing regimen is, right? So say, hey, what do you think your dosing regimen is? Because that may be different than what you actually prescribed. Or has someone made a change to it recently? Maybe you being the primary care person, her cardiologist said, oh, actually, they upped the dose recently. Or they did some change the regimen to maybe twice daily instead of once daily. Those are things you need to kind of take into account, right? And then, are they experiencing any side effects, right? So again, clinically, it looks like they're doing okay, but maybe they're having side effects, but they don't even realize it's due to the medication, right? So for digoxin, you don't have to memorize this for this class, but later on you will. For digoxin, you get these halos that appear around lights, and it has this kind of yellowing of the vision. It's called xanthopsia. You have nausea, vomiting associated with it. So you kind of talk to the patient and you see, okay, are you having any of these effects? You know, they just may think they're getting older, and they think, okay, well, maybe I just see halos now. That's just all it is. Maybe I'm close to death if I'm seeing halos. Maybe that's, but could be related to the actual drug they're on, right? So again, these are things you have to ask. So remember, when we're looking at these levels here, again, steady state level, we're looking at the bioavailability, we're looking at the dose they're taking, and then it's going to be divided by the clearance and the dosing interval, right? So we can look at all these factors to see, have there been any changes that had led this lady to have too high of a digoxin level, right? So the question with bioavailability, is she absorbing more than she's supposed to? Probably not. Probably she has pretty average sort of absorption of the drug. I wouldn't imagine that. However, you know, what if she was taking more than prescribed? Maybe she's absorbing more because she's taking more, right? That could definitely be one reason why the patient is getting too much in her system. From the clearance standpoint, do we think the patient's clearance has changed? More often than not, this is a big thing you're going to want to look for, is to see, okay, well, have they had a recent change in their organ function? It's really good if you can have a baseline to check against. Sometimes you will, sometimes you won't, but look at that delta there. Look between what they were at and where they're at now to see if there's any big adjustments you need to take into account. And then look at the dosing interval. Are they taking it more frequently than they should have? That could also be influencing the level here. So other things to consider, though, looking at the actual level itself, is the level wrong? Was maybe there's some chance that the assay was performed incorrectly? You know, you want to take into account, and a lot of people take for granted that the lab is always right, right? The value you get back is always correct. Is that always the case? Usually, yeah, but sometimes it may not be, right? So, for instance, sometimes you'll get erroneous lab values that will come back, and you know, say for instance, potassium is a big one. Potassium is one that oftentimes will look high, and is due to, anyone know what it's due to sometimes? Hemolysis, right? So if you have breakdown of the red blood cells, you can find that potassium will leach out and can be measured. If the lab doesn't report that there was hemolysis, guess what? You're just saying my patient has hyperkalemia, right? So those are things that take into account. Is the assay actually wrong? And then look for interfering substances. This is actually kind of an interesting one where one thing that you'll see in ICU patients, you can have patients who are in the ICU who have never touched digoxin, and they'll actually have positive levels. Because of the assay, there are certain stress products that your body can produce that actually will trip the assay. It looks similar enough to digoxin that it'll actually measure as such, right? And so again, there's rare instances, but there are times where you can actually have the assay be wrong because of that, right? So those are things you have to consider. Okay, so now what? Okay, so we have our ideas. What could be some reasons why the levels are too high? Let's look at some things we can try to account for. Let's confirm the sample timing. Let's make sure the level's done at the right time. Determine what the patient adherence is. Talk to them, see if they're actually taking it or if someone's giving it to them. Assess for other concomitant substances. Maybe an herbal product has come along. Maybe it's decreased the metabolism. Who knows? Do you want to repeat the sample? Maybe you repeat. If you think the lab was wrong the first time, maybe we can repeat it and see if it comes back high the second time. And then obviously determine bioavailability and clearance. Here, the clearance, you want to determine renal function. You want to look at that, but liver function may be appropriate depending on the drug you're dealing with. So again, looking at, is this an appropriate use for therapeutic drug monitoring? You know, do we have an adequate indication? Yeah, I think so. You know, the level looks, you know, we just started the patient on the drug. You want to see where they're at, right? You want to make sure they're at steady state and see what they're doing there. And again, you want to make sure the timing is going to be appropriate. So look at the dose when it was given, look at the time the level was done, and then obviously want to have a good rational interpretation here, right? Because again, even though the level's high, we said the patient looks good. Like, let's assume they have no side effects. Do we necessarily want to jump the gun and make any changes right this moment? That's a question we have to ask. So again, we suspect we have a high, good indication here. You know, either we have suspected toxicity, we have a newly initiated regimen, which is going to be with our patient, or if you have patients who have, like, say, organ dysfunction or maybe some variability in their organ function, high-risk patients, these are all really good reasons to do it for digoxin. Obviously, here we have a newly initiated patient. That's why we want to do it. Other things you may want to consider, you know, do you suspect there's been an overdose, drug interactions, pharmacokinetic changes? If you want to decide for future therapy, maybe if you check the level, patient's not getting any efficacy from the drug, you check a level and it's still in the right range, do you even want to continue that drug, right? Or if they're having too bad a toxicity, you know, they're at the therapeutic range, do you want to continue that? Those are questions you have to ask. And so some other things to consider. Okay, is the drug at steady state? Do we do the level too early, or do we actually do it at the right period of time to see is this actually appropriate? It's too high at this point, so we know that we're probably not checking it too early. It's probably not going to be a concern from that standpoint. Again, look at the sample timing. Did they take it right after the drug was given? That could have an effect here we'll have to take a look at, right? We're going to be asking about adherence, obviously the timing of the dose, sample collection. Now, you asked about blood sampling site. Sometimes what you'll find is that you have levels of a drug that will be done and they'll be extraordinarily high. You're like, what the heck? This patient's blood has been replaced with vancomycin. What's going on here? And you'll ask the nurse, hey, where'd you draw this from? They're like, oh, I draw it from the line where the vancomycin was infusing. Right, those are things like that. Now, as long as the line is properly flushed, right, then you shouldn't have any residual drug around there. It probably is not going to be an issue if you draw it from there. However, if you do like a straight stick or something to get a level, you're more likely to get an uncontaminated level. It's always the thing you want to consider with that. I had one nurse we had a snake bite patient one time, and one of the things you'll see with rattlesnakes here in Florida, they cause a lot of coagulopathies. And so one of the things we measure are PTINR, PTT, fibrinogen, all of that. And so we were measuring levels, and we saw the nurse actually getting patient was bitten, like say on the right arm, and they were drawing levels out of the right arm for the coags. I'm just like, well, the snake venom's right there. That's probably not a good indicator of what's happening systemically. You do it off the other arm. One time I saw them, they're actually doing blood pressure measurements off the arm that was bit. I was like, stop! Like, what are you doing? You're putting a tourniquet on. It's not good. Anyway, so those are things you have to consider, right? And then also some intrapatient variation. Every patient is going to be a little bit different, so these are things you'll kind of look at. Okay, some other things. Reasons why the levels might not make sense. I mentioned either the wrong dose was given. So for instance, if maybe, the pharmacy screwed up and was giving too big of a dose or too low of a dose, I hate to say that we're not perfect from the pharmacy department. We screw up just like everyone else does. Maybe the drug was given too quickly or too slowly. That could affect your levels. Maybe a dose was skipped or the infusion was held. Say, for instance, you had a patient who was in the hospital. They had to go get a scan. They had to go down to MRI for a scan, and the nurse wasn't able to give their vancomycin dose, and now the level's off, right? That could be a reason. If you didn't know that, then you wouldn't know the level would be off for any reason, right? And then, if the dose was given at the wrong time, but the blood was still drawn at the right time, based on your orders, it's still wrong, right? Or if the dose was given at the right time, but the blood was drawn at the wrong time, it's still wrong, right? So again, either case, you need to know that difference between the two time points. Okay, some other factors you have to consider, taking the sample through the administration line could be a problem if it's not been flushed appropriately. Sample taken from the wrong patient. I talked about in the NICU, we got 3 sets of twins, baby A and baby B, and baby A's in the B bed, and baby B's in the A bed, and you can see how it can get that screwed up. So if you were to check a level to 0, one question you might want to ask, like, well, is it even the right patient? It could be a consideration there, right? Sample handling issues can be a problem too. So imagine if certain labs have to be kept at a certain temperature. If they're not, they're kept at too hot or too cold. That could be something that can lead to some issues. Or if the wrong collection tube is used, as we mentioned. So a couple other things, and again, I'm almost done, so that's why I want to just finish out this section here. Again, the patient kinetics, maybe they fall outside of what the population norms are, and so because of that, this is why the levels may not make sense. So you can have someone who is outside of the range, but is not having any problems and doing really well. Doesn't mean you have to necessarily change the dose, right? Again, the levels drawn prior to steady state, that's obviously going to be falsely low, so you have to consider that. And again, looking here, you actually can find blood drawn at the inappropriate time can actually alter the kinetics, or it can actually kind of illustrate a certain kinetic principle. So some drugs will have what we call a distribution phase, where basically as it gets absorbed into the system, it takes time before it will distribute out into the tissue. It's not to say that the volume distribution is any lower, it just takes time for that to happen. And what we'll actually find with digoxin, it actually has a distribution phase of about 6 hours. So if you measure that before the distribution phase, all that blood, or the drug is still in the blood, guess what? Those levels are going to look too high. So we're actually going to see that's what the problem is with some other things, if the wrong drug was assayed, so again, they got a level for doing for phenytoin and actually measured a valproic acid level instead, that would obviously come up wrong. I talk about interference with endogenous substances with digoxin, like critically ill patients, improper storage, technical errors of the assay. Those are all things on the lab side that could be an issue. You have to potentially try to investigate if the levels still weren't making sense based on what's going on with the patient. Okay, so anyway, with this case, let's say digoxin has a 6 to 8 hour distribution phase, and again, if you draw the levels too early, they're going to look really falsely elevated because they're still there in the blood before it distributes out into the tissue. And so in this case, you talk to the patient, find out that, oh, they took it 2 hours, their dose was 2 hours before they actually got the lab done when they went into your office, right? So again, when you repeated it at 6 hours, later, it came back and it was 1.1 nanograms per ml. It's in the right range, and now you don't have to have any intervention. But remember, if you just work off that one level, that initial level you had, you're going to think it's too high. We need to get this patient down on a lower dose, right? So again, you have to take all of these things into consideration. And as a provider, when you get into kind of your niche and wherever you're going to be working, you'll get very familiar with the drugs you're going to use. I think you're going to learn hundreds of drugs from me, but in the end, I think most providers' armamentarium of drugs is probably like 80 to 100 drugs or something you'll use at max. You'll get very comfortable with those and know all these little idiosyncrasies with them, right? So anyway. Again, always the best outcome is I don't have to do anything at all, right? So if I can do the investigation, say, all right, I don't have to change anything, then that's always good. So anyway, so again, make sure you're trying to use rational decisions here when you're ordering levels. Make sure you're ordering a level with a certain intent. If you order a level and it actually doesn't matter what it comes back as, if it doesn't make any difference in your treatment, consider whether you actually need it in the first place, right? So and we'll talk about drugs as we go forward in the Pharm 1 and Pharm 2. We'll look at those specific examples when it's appropriate to do so, when it's not, and you'll have a good feel for that then, okay? So I know it was quick, but I wanted to make sure I can get to the last section, cover that next week, and then have a little bit of time for review for you guys and give you some, we'll go over writing prescriptions a little bit more. So again, the homework assignment is posted, but you may want to wait till next week when we kind of go over that, and then it'll make a little bit more sense, okay? Any questions? All right, I will see you guys next time.
Aww.